to thank the National Indian Health Board for hosting this very important webinar as we face different battles during the COVID pandemic. My name is Otakuye Conroy-Ben. I am Oglala Lakota from the Pine Ridge Indian Reservation in South Dakota. And I am a wastewater engineer. I have been working in this field for over 20 years. And I'd like to share with you some of our work that we're doing with tribal communities and wastewater analysis of SARS-CoV-2. I have a number of partners that I would like to highlight here. I'm working with the Intertribal Council of Arizona, as well as other programs here at Arizona State University. So during the pandemic, we have seen various waves of coronavirus come through globally as well as nationally and with our tribal partners. For many of these peaks, we've seen that cases and deaths impacting tribal communities have surpassed the rates in other races that have also been tracked during the pandemic. This is true with cases as well as with deaths. And so to really get a handle on these fluxes, clinical cases, one way we can track coronavirus at the community level is to look at wastewater. So to really see where we can implement this type of work, we mapped all of the tribal wastewater facilities that have discharging permits within the United States. You'll see in the map up above with the United States as well as with Alaska Natives, the symbols, the blue and the red diamonds depict where there are wastewater facilities within tribal lands that are discharging to surface waters. We wanted to see if which tribes across the US can use wastewater-based epidemiology. So taking that wastewater sample and analyzing it for coronavirus. Among the 574 federally recognized tribes, there are 326 with a land base. And out of those, 105 tribes do have NPDES permits, which are basically wastewater permits that allow you to discharge. So this gives us an idea of which tribes actually have centralized wastewater systems. And from these tribes, we can go speak with them to see if they have the interest in looking at wastewater epidemiology. Now, there are a number of other tribes that do not have surface water discharging permits. And so my colleague, Dr. Becca Munich, as well as the Intertribal Council of Arizona, is collecting data on other wastewater facilities that don't discharge and hence are not in publicly federal databases. With this, they're looking at satellite imagery to detect wastewater lagoons in remote areas. And details of that GIS work is shown here in the lower right. There are 248 other tribes that do not have a reservation land, and therefore they would not have NPDES permits collecting from their communities. So these are publicly owned treatment works, POTWs, that discharge to the environment. There are other wastewater facilities, such as those under jurisdiction under the Indian Health Service, school lagoons managed by Bureau of Indian Affairs and Bureau of Indian Education, and then privately operated wastewater treatment facilities. So for those facilities, we haven't done any outreach simply because that requires another in-depth layer of approvals to sample their wastewater. So we have these 100 tribes that can use wastewater-based epidemiology. So what do we do with wastewater-based epidemiology? In an NIH-funded project, we are recruiting up to 10 tribes to look at coronavirus levels in wastewater. In figure 1, the basic setup is that we take sewage collected from pipes from a sewer shed, and we collect that untreated wastewater before it hits the wastewater treatment plant. Then on the right, again, is those tribal facilities shown. And so we looked at which tribes can do this work, and then we reach out and we see what is their tribal research policy. So in this NIH project, we're engaging with tribal partners. We're working with Intertribal Council of Arizona, and we're developing this tribal coordination center. We have a multi-layered approval process to get tribes onto this project, and I'll talk about that in a second. Once we have approval to work with tribes in wastewater monitoring, we measure coronavirus levels using qPCR, as well as we look at protein sequencing. Another aspect of this project is to look at the sewer shed to figure out where is the best place to collect wastewater to get that maximum signal, and also to see if there's any risk associated with working with untreated wastewater. This process requires tribal consultation and approval. We also have approval procedures here at Arizona State University. Once all of those are set, we coordinate with the tribal utility and tribal health boards for this respective tribe. And we will go out and we start to sample the wastewater. Those samples are brought back to ASU and analyzed in the lab of Dr. Haldick for coronavirus levels. And we understand that tribes own all of their data, and so we return all of this data back to the tribe. I really want to focus on the tribal approval process because there are likely a number of organizations and tribes on this call who are interested in this type of work. But we really do need to have that approval in place before we take environmental samples from your tribal lands. We consider this research. So we go through institutional review boards, research review boards, health committees, tribal councils, in order to get approval to collect samples and analyze them. So to date, we've been communicating with about 20 different tribes to see if they are interested and is this even a feasible process. For 4 of these tribes, actually 5 of these tribes, they have an IRB. For 6 of these tribes, they do not have an IRB, but we have to go through their health committees, which then, if approved, this project goes to tribal council for a resolution. There are tribes that have other approval processes, such as research permits. And there are tribes who really have not engaged in research much. And so they don't have a process yet for conducting research and for data sovereignty. And in those cases, we really can't do much unless the tribe has those policies outlined specifically. Because we are in Arizona, most of the tribal inquiries have been with the tribes associated with the Intertribal Council of Arizona. We submitted 12 full tribal applications. 5 of those have been approved, meaning we're currently working with 5 different tribal partners. 5 have been denied for various reasons. The process to get these approvals, the timeline varies from a week up to over a year, as tribes do need to consult with their legal teams. The feedback we received with this type of project is that utilities understand the importance, wastewater utilities, in monitoring for wastewater pollutants, so they are very interested in this type of work. Tribal health boards also find this to be an innovative method to track coronavirus in the absence of thorough clinical testing. In some cases, tribes have complicated water rights. Some tribes are just generally not interested, or they don't have the staff to really take on this type of work and be a full partner in this project. And so we do need that approval, and that has been the most time-consuming portion of this project. We have to look at IRBs, resolutions, memoranda of understanding or agreements, material transfer agreements. So actually taking that wastewater sample from your tribal lands and agreeing to only analyze for coronavirus. We may have to fill out applications and do proposals, as well as present to your tribal leadership. So that building of that tribal partnership is really critical. Our ASU Tribal Research Review Board is present at all stages. We found that tribal utility and staffing, as well as sewer access, are limited. We're working in remote areas, and travel time, sample location, that collection and delivery are also challenges. Also, we're learning more about each tribal partner's data sovereignty agreements, who owns that data, what can be shared, what cannot be shared. And we also have to relay what are the federal reporting requirements, being this is an NIH funded project. This is wastewater-based epidemiology in practice. So these are photos from actual sample collection sites. So a background on wastewater-based epidemiology. We're taking that wastewater, we're taking excreted human waste and measuring biomarkers in both urine and solid waste. And this waste actually contains some critical health biomarkers, such as substances you've ingested, including drugs, contaminants. And then if you are infected with some type of disease like coronavirus and it is excreted, we can develop methods to track that. As stated earlier, there are about 100 tribes that have centralized sewer treatment in the US. And those are the tribes that can participate in this type of study. We do need to assess the wastewater infrastructure. So we take a look at your sewer lines, lift stations, as well as wastewater treatment facilities. My background in wastewater engineering gives me that ability to really see if we can bring this to your tribal community. Advantages to wastewater-based epidemiology in tribal communities. This is nice in that we can rapidly assess community level health. This is anonymized, it's non-invasive sampling. We're not asking for biospecimens, and we're only analyzing for what the tribe has permitted us to analyze for. Some disadvantages, sewage contains human pathogens. So we typically require additional immunizations for workers coming in contact with these samples. We also need to know something about how many people are contributing to the sewer line, as well as those sewer flow rates, because those can impact the concentration of coronavirus that we are measuring. We collect, in most cases in these remote areas, not from the lagoon or the treatment facility, but from the sewer line feeding into those facilities. And so some locations will have these automated auto samplers. Let me see if that's my laser. On the lower left, this is an example of an auto sampler that collects wastewater for 24 hours at defined intervals, volumes, and types. In many cases, our tribal partners do not have this type of sampling equipment, so we take our own sampling equipment shown in the right-hand panel as well as in the second picture. This is a portable ISCO auto sampler, which again is pre-programmed. We can tell it to pick up a certain volume at certain time intervals. These have to be lowered into sewer lines, shown here on the right. And then we suspend them. We come back 24 hours later and pick up those samples. Once we have those samples, this is the pipeline that Dr. Halden's lab uses for both quantification of coronavirus as well as sequencing of the proteins. So on the right-hand side shows that we take that water sample, the virus is concentrated, and then they use a commercially available kit that quantifies 4 different genes of your coronavirus particle. And once all that is analyzed, we'll get back a concentration, and then we look at trends from month to month, and that is reported to our tribal partners. They're also interested in looking at the protein sequence. In many cases, wastewater is a very harsh environment for coronavirus, and that RNA can be unstable, especially if we're transporting samples from a remote community that has to be driven to the nearest town and then FedEx. So it can be a few days before we actually get that sample. So an alternative to looking at the variants, as well as just to see if we can detect coronavirus, is to look at the protein, which is much more stable than RNA. In another aspect of our project, we're looking at sewer sheds to see where we have the best RNA signal. And that's, again, just to really get a good quality analytical data for the tribes. Dr. Carrie Hamilton, she is a quantitative microbial risk assessment specialist. She has been working on developing a risk assessment model. These tribal lagoons are not disinfected, so they have the potential to harbor a number of different pathogens, including SARS coronavirus. And so she's developing this model, this risk model for people who may be in contact with wastewater on a regular basis, typically through occupational exposure. And this risk model is not fully online yet, but she is developing models for not only coronavirus, but for other infectious diseases that can be found in water. All of this data is being used to improve tribal health, to reduce the COVID-19 impacts, as well as to inform all of our tribal partners, both on the utility side as well as health-based side. Where else are we making impacts? We are developing the Tribal Coordination Center as we bring on more tribal partners, and that website is under development. Our tribal partners have asked for data dashboards, which would be solely for their use. They may not take these public. We're developing a tribal wastewater-based epidemiology training program in collaboration with Navajo Technical University. And this summer, we are partnering with other schools across ASU to discuss coronavirus microbiology to tribal high school students. My colleague, Dr. Ralph Halden, has taken this coronavirus monitoring and informed an Indigenous community, shown in the upper right. This was highlighted in AZ Central in, I would say, the fall of 2020. Due to the proximity of Tempe to neighboring tribal communities, and the fact that he had already established a partnership with the city of Tempe, as soon as the pandemic hit, he was monitoring the Tempe sewer shed. And the town of Guadalupe is bound both by Tempe and Phoenix, and is home to the Pascua Yaqui tribe. And so he had been monitoring these areas and found that in this particular sewer area, there were elevated coronavirus levels, and that data was taken back to their community, and they were able to implement stricter measures and get a handle on the coronavirus pandemic during that initial wave. We're also using wastewater-based epidemiology to measure drugs of abuse. This paper came out, I would say, a few weeks ago, where we looked at substance abuse consumption, drugs of abuse that are consumed, sorry, in a number of tribal sewer sheds. And I encourage you to read this if your tribal community is interested in this type of work. This is also in collaboration with Dr. Halden's lab, who has very nice mass spectrometry equipment. His lab has the ability to measure illicit prescription drugs. And in our study where we looked at 6 different tribal sewer sheds, we were able to detect drugs of abuse to very different degrees. Some communities had indicators of large drug consumption, whereas some communities, we couldn't really detect drugs of abuse in their sewer. And so we hope to expand this work and work more with tribal communities to look at substance abuse problems. Other wastewater-based epidemiology projects that I'm undertaking, we're looking at sequencing positive wastewater coronavirus samples. This is in partnership with Intertribal Council of Arizona under their Native American Research Center on Health program, NARCH, which is funded by NIH. Looking at a specific type of sequencing as well as protein modeling. Also looking to expand wastewater-based epidemiology by developing that foundational framework, evaluating tribal perspectives and priorities when using wastewater-based epidemiology, and then doing some exploratory work with my tribal partners. I wanted to leave you with, what is going on most recently. As of this morning, actually yesterday, New York Times reported that the Omicron subvariant BA.2.12.1 is the dominant form among US cases. And if you look at GISAID NextStream's website, you can see that as they track Delta and Omicron over the past 6-8 months, you can see the emergence of Omicron recently in May. This is the red that is increasing in the plot. That is that Omicron 22C or BA.2.12.1 that is emerging here in the US. Okay, this is my team. The PIs on the project are Dr. Ralph Halden, Carrie Hamilton. We have other PhDs, Aaron Dreyer, Rebecca Munich, and Carrie Joseph, who are working on various aspects of the project, then our partners at Intertribal Council of Arizona. Ms. A.P. Lamia, and I want to acknowledge all of my investigators, partners, our funders, NSF, Katina, NIH, and Rockefeller. And if your community, or if you as a utility manager or health director are interested in this type of work, please contact me. And now, I guess if you have questions, please put them in the chat. Otherwise, I'll turn it over to our speakers from CDC.
Great, thank you. I am happy to be here. My name is Amy Kirby, and I'm the program lead for the National Wastewater Surveillance System here at CDC. I'm going to pull up my slides and turn off my camera because I'm having not great internet connection today. So hopefully turning off my camera will help during the presentation. All right. So what I want to talk to you about this afternoon is more of a high-level perspective of the National Wastewater Surveillance System, which we call NWS. So thinking about how we're supporting these wastewater surveillance efforts around the country and what sorts of support is available to communities that are participating in the NWS system. So there's 4 primary advantages for using wastewater surveillance to get that situational awareness for COVID-19 in our communities. The first is we know that somewhere between 50 and 80% of individuals that are infected with SARS-CoV-2 will shed detectable viral RNA in their feces. And this shedding happens whether they have symptoms or not. It happens in both in adults and children. And so what that means is that by using wastewater as essentially a pooled community stool sample, we can get information on the full spectrum of infections in a community, which is very different than what we see with clinical surveillance, which is primarily going to detect symptomatic cases and severe cases. Second, and I think most powerfully, wastewater surveillance is completely independent of healthcare seeking behavior and testing access. So what that means is it doesn't matter if people go to the doctor, it doesn't matter if they are able to get tested. And increasingly now, it doesn't matter if they're using home tests that aren't reported to the health department. We can still get information on the number of cases in a community using wastewater surveillance, as long as they're using toilets that are connected to sewer systems or some type of shared sanitation system. Third, it's efficient. A single wastewater sample can represent hundreds or thousands of people. In our largest communities here in the US, that single sample may represent millions of people. And finally, it's fast. From the time a toilet is flushed until we can have data in hand is about 5 to 7 days. And we've seen consistently throughout the pandemic that we can detect trends in wastewater surveillance about 4 to 6 days before we see those same trends in case data, and about 10 days before we see those trends in hospitalization. So it is serving as that leading indicator of what's going on in communities. And we found lots of uses for this information. What we hear most frequently from our public health partners in state and local health departments is that they find wastewater data to be very useful as independent confirmation of true increases and decreases in cases. And the way they often vocalize this to us is they say it gives them confidence that they really know what's going on in their communities. Because again, all of those other indicators that they're looking at are linked to clinical care and testing. And so they can be impacted by all of those access factors, and wastewater is not. So it helps them understand what is truly signal versus noise in all of these indicators. And then they're using that information primarily to make decisions about resource allocation. What communities are you going to prioritize for the siting of mobile testing capacity? What hospitals are you going to provide additional resources because they may be getting more cases in the next couple of weeks? And how are you going to provide the appropriate messaging for communities so that they know what is going on and people can make decisions to protect themselves, their family, their staff. And we're also seeing this, as Dr. Conroy suggested, being used to detect the emergence and spread of variants of concern in communities. The National Wastewater Surveillance System has grown very quickly since it was established in September of 2020. This map shows all of the sites that are submitting data into the CDC system. The dots are scaled by the size of the population that's represented in that sample. We have over 900 sites that are currently submitting data to CDC. That's over 110 million people. So we're already covering more than 30% of the US population. Our primary way of supporting wastewater surveillance in the United States is through the Epidemiology and Laboratory Capacity Cooperative Agreement. We have 37 states, 4 cities, and 2 territories that are using those ELC-provided CDC funds to support wastewater surveillance activities. Unfortunately, tribal partners are not directly eligible for ELC funding, so we have looked at other ways to support tribal engagement in wastewater surveillance. And one of the ways that's available now is through a commercial testing contract. So in addition to these state and territory-led systems, we also have this commercial testing contract that provides twice weekly testing at an additional 500 sites nationwide. And there we are eager to have tribes participate. And we do have some tribal participants already, and there are still spaces remaining in that contract. So if you are interested, please reach out to us. And then all of this data is available for public use through COVID Data Tracker. The real heart of our system is our data system. So this is a screenshot of our Decipher data dashboard. So Decipher is the software platform that we use for all of our COVID surveillance here at CDC. We have a wastewater dashboard within that Decipher system, and this is what it looks like for our health department partners. And really, the key to understanding wastewater data is that the concentration that we measure at a particular site or in a sample is not directly comparable to the concentration measure from another site, because the way the wastewater system itself is set up and operated will impact the number that you get in that sample. And so we have to use higher order analyses in order to make this data comparable. And so the table presented here shows you the metrics that we rely on. Our real workhorse is percent change. And so that's telling you if concentrations are going up or down and how quickly they're changing. And then we also look at a percentile metric, which is a comparison of the current concentration to all of the concentrations that have been measured for that site over time. And essentially asks, is this current measure, is it within the top 20% of concentrations ever measured? Is it within the bottom 20%, or is it somewhere in between? So it gives you a measure, sort of relatively speaking, how high is this measure for this site? And then finally, we also have detection proportion. This is looking at all of the samples that are collected in the last 15 days. What percent of those samples have any detection at all? Right now, with as many cases as we have, this is not a particularly interesting metric because all of our samples are positive, or the vast majority. But when we're in very low incidence periods, this detection proportion is where we're first going to detect reemergence of SARS-CoV-2 infections in a community. So very important there. And then finally, we can do all of these metrics with any of the variants. So right now, our system is presenting data on the Delta and the Omicron variant, but we are about to stand up a new sequencing-based variant tracking module, and that will enable us to do these same sorts of analyses, looking at some of these sublineages that are of interest with Omicron, like the BA.212 that we were just discussing, as well as any new variant of concern that may arise. Variant tracking is clearly something that's of great interest for people that are doing wastewater sequencing. But I do always take care to note that we have to be very careful with how we interpret that data. The vast majority of the virus RNA that we're detecting in wastewater is from decaying viruses and is already fragmented genomes. So while we may be able to detect, say, all of the mutations that are associated with a variant like Omicron, we can't say with confidence that all of those mutations are present on a single genome. It could be that it's a mix of variants, each carrying some subset of those mutations. And so we need to be very careful with how this is interpreted. It's also not particularly sensitive. So when cases are very low, the sequencing methods that we use to track variants in wastewater will not work for us because there's not enough genetic material there. So there are some limitations there. And I'll finally note that we really don't have any information on how shedding and feces may change between variants. All of the data that we have on fecal shedding comes from early 2020 studies, so even pre-alpha. And so it's really not clear if these more recent variants, particularly thinking about like Delta and Omicron, have the same shedding profile. So really important to think about that when we're thinking about proportions of variants in wastewater. However, variant tracking in wastewater can still be quite useful. We have an MMWR, this is a morbidity and mortality weekly report that was put out by CDC staff and 4 of our state partners. looking at the earliest detections of mutations associated with the Omicron variant in wastewater. And I'll just briefly note that those top 3 locations, California, Colorado, and Houston, those detections in wastewater came after they knew there were clinical cases in the state. But those wastewater samples suggested that the Omicron variant was much more widespread geographically in their communities than the clinical cases suggested at the time. And then the last one, that detection in New York City, that was in a wastewater sample that was collected November 21st. That is still the earliest known confirmed presence of the Omicron variant in the US. The first clinical case, that sample was taken on November 24th. So it can also be a very early indicator of the presence of these new variants of concern. One of the things that I am most excited about for wastewater surveillance is that we can potentially use this to address health equity issues. The first step to being able to address any kind of health inequity is to be able to describe it and understand the scale of it. And that's really where surveillance data comes in. And for news, we do this in 2 different ways. So at the community level, we think about prioritizing access to this new tool in rural communities, those with a high social vulnerability index, with low vaccination coverage. We want to make sure that we reach out to those communities and that they have all of the resources and tools that they need to participate in news so that they can get the benefit of this. You can also think about it at the facility level. So just like you can take wastewater at a treatment plant, you can also take wastewater coming out of a building or out of a facility and test that. We have a pilot study looking at on-site wastewater testing in correctional facilities. So this kit that I'm showing here, this is the Lumen Ultra test kit. It allows you to take a wastewater sample and within 4 hours have a quantitative PCR-based measure of how much SARS-CoV-2 RNA is present in that wastewater. So very efficient for that facility-based testing. And we've seen it be quite successful in these correctional facilities. So we've already had several situations where the wastewater testing has been the first indication that there's any cases present in the facility. And then what we hear from the correctional facilities themselves is that they find as much value in being able to track the trajectory of the outbreak through wastewater as in that initial detection, particularly when they're on the downslope of the outbreak, right? They can see that cases are coming down. They can continue to track that, see the wastewater go back to negative and non-detect. And then if the wastewater stays negative for a week or more, they know with great confidence that the outbreak is in fact over and they can relax their mitigation measures. So finding real value in this at all stages of the outbreaks for facility level surveillance. And finally, I just want to note that we are already thinking about expanding news to pathogens other than SARS-CoV-2. We really built this system from the beginning to be a flexible surveillance platform for multiple health targets. And we really want this to be a system and an infrastructure that can rapidly adapt to changing public health needs. And in that little table there down on the left, I've given you some examples. Pandemic preparedness, clearly news was built for a pandemic. So having it already intact, should there be another pandemic, we'll be able to scale up much more quickly. Emergency response, I think, is a really interesting potential application here. I'm a water microbiologist, so I think a lot about water-related emergencies. And often in the wake of hurricanes and floods and other water-related emergencies, we get concerned about the potential for waterborne infections like Shigella. And there's often not much we can do other than message to the public health community, encourage people to wash their hands, use good hygiene. But really, we're waiting to see if anything happens. If we have wastewater surveillance infrastructure in those communities, you can think about a short-term activation of just that local wastewater surveillance infrastructure to look for pathogens like Shigella. So we can actively do surveillance for these waterborne infections that we're concerned about in the wake of these emergencies. So I'm really excited about the potential applications there. We can also use it to get information on emerging infections. So when we have these very rare new infections, things like Candida auris or enterovirus D68, we often only see the most severe cases in the clinic and don't really know much about the presence of those in the community. And wastewater surveillance gives us a very low barrier to entry. So we're already collecting the sample, we're already getting the DNA and the RNA. Adding one more test for these pathogens is not a very high bar. And so we can get that community level information relatively easily on these new emerging infections. And then finally, there's potential applications for bioterrorism as well. If we are concerned about a threat or we know there's been some kind of an event, we can do another regional or local activation to get more information to know how widespread that agent might be. For the first, what we're calling the news panel version 1.0, we are looking at some of the targets listed here in the table on the right. So primarily antibiotic resistance genes. So thinking about those that are very clinically relevant. So carbopentamases, extended spectrum beta-lactamases. We're also thinking about foodborne infections, things like Salmonella, E. coli, norovirus, influenza, and other respiratory viruses is another target that's not listed here, as well as the emerging fungal pathogen Candida auris. We expect to have this first panel available for pilot testing in a few of our locations by the end of this year or early next year. And then barring any huge technical difficulties, we'll be expanding to the full system sometime next year. And then the expectation is that this will be an iterative process. So every year we'll be sitting down with a panel of experts here at CDC to review what we are looking for in our panel, make sure we're still looking for the right pathogens, that we're looking for the right targets within those pathogens, see if there's anything else that we need to add to our panel or things that we need to drop, and making sure that the data we're collecting is collected in a way that is useful for each of those different surveillance programs, so that this really is a data system that's being used widely, and that we're not just collecting data just to have it, but so that it's actually used. That said, there are still a lot of challenges left with news. We will never be able to get to 100% population coverage, because we know that about 20% of the US population is not connected to a sewer. And so they're not going to be as accessible through wastewater surveillance. We also need to be really careful with how we message around negative results. It's very intuitive, especially with the public. If you have a positive result and it's meaningful that there's COVID in your community, that a negative result must mean that there's no COVID in your community. And that's not true for wastewater surveillance. We know that if incidence is very low in a community, we will not be able to detect it. So we need to be very careful to make sure that people don't interpret this as clearing a community of having these infections. And finally, there's some barriers to implementation. We need to make sure that, as we heard from the previous presentation, a lot of the capacity right now sits in academic laboratories, and they have been great and very critical partners, but they are not really designed to do long-term surveillance. And so we need to bring this surveillance capacity into our public health labs so that we can free up our academic partners to continue doing the research to drive this system forward. And then this is just a few other things that we want to think about. I particularly want to note, again, we need more information on the impact of vaccination and variants. We really don't have any information at all on how vaccination impacts shedding. We know there are breakthrough cases, but we don't know if they are also shedding detectable RNA in their feces. So we need more information there. And then finally, I have to say that there's ethical issues associated with wastewater surveillance. There's a lot of DNA in wastewater, and so we need to be cognizant and very transparent about what we're doing. Primarily, there's issues around privacy. It would not be trivial to do, but potentially a person could be identified out of wastewater, and so we need to be real clear that we are not doing that. The assays that we are using do not target human DNA. When we do sequencing, we scrub out any human DNA that comes from that and make sure that people understand that we are taking every step we can to protect privacy. Second, there's questions around consent. Who gets to make decisions about whether or not a community's wastewater is tested? And we heard some conversation about that in the previous presentation as well. Third, there's concerns around stigma. We have seen that happen with other infectious diseases in the past, where gathering information around the prevalence of a disease has inadvertently stigmatized a community. And we certainly don't want to do that again. So we want to be very careful with how this information is described and relayed to the public. And finally, there's questions around future use. And so what this means is, it would really be great if we could store these wastewater samples, because, wouldn't it be great if we could go back to stored wastewater samples from 2019 and look at the history of COVID as it emerged in the US and around the world. And certainly there's going to be other applications we would like to use in the future. However, all of those ethical issues will continue to exist for that future use. And so we need to be very clear around who is going to be making the decision about what these samples can be used for, and if there are things that are entirely out of scope for the use of these samples. So we need that kind of future use planning in place as we start any efforts towards wastewater archiving. So lots of thinking to do there, and these are all things that CDC is either doing ourselves or working with partners to move forward in the next year. And with that, I know we're very close to the end of time. If you have questions or would like to participate in the contract particularly, please reach out to us at nwss@cdc.gov. You can also get more information on the program overall at www.cdc.gov/news NWSS. And with that, I will turn it back over to Adriana.